Hello, good afternoon from London. This is the 10th anniversary of the Imperial valve course that started 10 years ago and is dealing with all sorts of cardiovascular interventions, particularly valves, but also coronary artery disease, difficult cases, chronic obstructions, chronic occlusions, as well as devices in different parts of the heart, PFOs, atrial septal defects, PDAs, etc. There is an amazing international faculty from all over the world, particularly Europe, with the experts in interventions, leaders in TAVI and mitral clips that dominate the annual meeting. This year particularly we had a very strong input from Greece. There have been a fantastic speaker talking about the Pascal device, a new clip device, and edge-to-edge device, as well as for the use in tricuspid valve regurgitation. What impressed me is overall, over the years, I have been involved in this meeting. I'm one of the co-organizers, and looked at how these interventional procedures developed over the years. We started with TAVI procedures, but now TAVI is well established, is part of the clinical routine worldwide. There are hundreds of thousands, if not millions, of TAVI patients being treated successfully. And at present, the challenges are with mitral valve regurgitation, that techniques evolve rapidly, and we are living the current challenges. The future is tricuspid valve regurgitation, and already during this meeting we have seen experts presenting devices closing or reducing the amount of tricuspid regurgitation, which is the next big hit in line. I've been talking particularly during this meeting for the challenges involving quantification of mitral regurgitation, particularly after publication of two pivotal studies, the mitral FR and the COAPT study, either side of the Atlantic Ocean, and providing controversial and exactly different opposing results. But this is probably to do with patient selection rather than techniques. And from my point of view, evaluating the true severity of mitral regurgitation is still challenging. Guidelines have changed since 2003, went through 2014, revised criteria in 2017 to understand now that an effective regurgitant orifice area of 40 millimeters square is more specific, whilst an effective regurgitant area of 20 millimeters square is more sensitive. So depending on the right ventricular volumes and the left ventricular end diastolic volumes, which are very, very important in estimating severity of mitral regurgitation, are coming into practice, and people need to understand that one single number is not enough, and you need to look at the severity of mitral regurgitation more holistically and add more parameters in evaluating the degree and the severity of mitral regurgitation.